Thank you. Hello, everyone. Welcome to the Medexus Pharmaceuticals Key Opinion Leader webinar to discuss the clinical data supporting Triosulfan, a first-in-class conditioning agent for hematopoietic stem cell transplantation. Before we begin, I would like to remind everyone that this presentation and discussion may contain some forward-looking information. I would encourage you to review the disclaimers on the slide presentation, which will be made available after the webinar. As a reminder, following the presentation will be a question and answer period. Questions can be emailed into info@adcap.ca or entered into the Q&A box below. Now I'll turn the call over to Ken d'Entremont, who's the CEO of Medexus Pharmaceuticals, for introductory remarks.
Thank you, Tina, and thank you to everyone for joining us on this call today. As you all know, on Tuesday of this week, we announced a transformative acquisition licensing deal for Triosulfan from medac GmbH in the United States. This is a very, very important addition to our portfolio. First and foremost, because this is an opportunity for us to help patients who are suffering from some very debilitating diseases. As you may know, we're excited also because this is a very near-term opportunity. Triosulfan has got a PDUFA date of August of this year. And so, we're 6 months away from what we hope will be approval of the drug in the United States. This drug also has already received orphan drug designation, so we certainly expect that at approval, it will be afforded a 7-year period of exclusivity. We're also, obviously clearly excited because this is a very innovative drug. Triosulfan will be the first drug in a new class of conditioning agents called reduced toxicity conditioning. Basically combines the increased tolerability when compared to myeloablative strategies with improved survival outcomes as compared to reduced intensity regimens. So this basically, combines the positive aspects of those two strategies into one drug. So we're very excited at the innovative nature of this drug. This drug's got excellent, clinical evidence, and that will be described by Professor Deeg, who is an expert in the field, and we're eager to hear his opinion on the drug. There is a new drug application which has been filed. We have now passed the mid-cycle review. The data that the FDA is reviewing is the full data package from a pivotal phase 3 study with 570 patients with AML and MDS. And this data package includes superiority testing. So the label that we may receive could be even stronger for Triosulfan if approved. The interim results of this same study have been published in Lancet in the past year or so. Our experience with the drug in Canada over the last couple of years via the SAP process, plus the extensive research that we've done in the US, makes us believe that Triosulfan has the potential to become the standard of care in this area. And so we're very excited to hear from Professor Deeg. And before we go there, I'm going to turn it over to Mike Edelman, who is the general manager of our US affiliate, who can give you, a brief summary of the market in the United States.
Thank you, Ken. Triosulfan was developed for use in allogenic hematopoietic stem cell transplantation, or allo HSCT, in which blood stem cells found in the bone marrow of a matched donor are infused into a patient's blood. This procedure is the only potential curative treatment for several types of both malignant and non-malignant diseases. Before receiving healthy blood stem cells from donors, patients' diseased bone marrow cells must first be destroyed by using a conditioning therapy. These are regimens that typically combine multiple chemotherapy agents and also radiotherapy very commonly. Triosulfan is a water-soluble powder reconstituted for injection into patients that belongs to a class of chemotherapy agents called alkylating agents. And triosulfan is used in conjunction with another chemotherapy agent called fludarabine as part of a conditioning treatment regimen. Alkylating agents briefly work by preventing disease cells from multiplying and proliferating by damaging the DNA of the disease cells. Triosulfan has demonstrated an increased rate of event-free survival and overall survival 2 years after allogeneic transplantation compared to the current standard of care in the pivotal phase 3 study, and is particularly associated with clinically meaningful survival benefits with higher risk allo-HSCT patients, like those with advanced age or comorbidities. Triosulfan has also demonstrated a favorable toxicity profile in multiple studies, supporting its safe use as an effective conditioning therapy for blood cancer patients, like those studied in our phase 3 program with AML and MDS. You advance, there you go. Triosulfan is actually already available in both the EU and in Canada. Back in June of 2019, the European Commission granted marketing authorization to Medac for Triosulfan in Europe. And currently Medexus is distributing Triosulfan in Canada via our special access program during the ongoing regulatory review process, which started in 2020. And Health Canada had at that point granted an expedited review cycle for Triosulfan. In the US, FDA granted Medac orphan drug designation for Triosulfan back in 2015 for conditioning treatment prior to allo-HSCT in malignant and non-malignant disease in both adults and pediatric patients. So as Ken indicated, if approved, Triosulfan will be the first and only alkylating agent clinically evaluated and approved for allo-HSCT conditioning. And then the PDUFA date, of course, is in August of 2021. Just a note on potential market size. According to the most recent data from CIBMTR, the Center for International Blood and Marrow Transplant Research, there were over 9,000 allo-HSCT procedures performed in the US in 2018, the year most recently available, with year-over-year growth of around 3%. Incidentally, another 14,000 autologous HSCT procedures were done in that same year. This is a similar type of procedure, but not one in which Triosulfan was studied, but one in which alkylating agents are typically used as part of conditioning regimens. So at this point, it is my distinct pleasure to introduce Professor Joachim Deeg to walk us through a summary of the data for the extensive phase 3 clinical development program behind Triosulfan. Professor Deeg is an oncologist at the Seattle Cancer Care Alliance, Professor of Medical Oncology at the University of Washington School of Medicine, and Professor of Clinical Research at the Fred Hutchinson Cancer Research Center. He is an internationally renowned expert in bone marrow transplantation, as well as myelodysplastic syndromes and myeloproliferative neoplasms, and he's got over 40 years of clinical experience in treating blood disorders. In addition, he participated extensively in the clinical development program for Triosulfan, and his center is currently conducting several investigator-initiated studies of Triosulfan. So welcome to Professor Deeg.
Hello, thank you for the introduction, everyone, and good morning or good afternoon, depending upon where you are, I suppose. Yes, it is my pleasure to make a few comments from the practice point of view in regards to Triosulfan. As indicated, it has been tested now in a number of trials the largest one being the randomized phase 3 study conducted in Europe. But we have transplanted here at our center, I think in excess of 450 patients for both malignant and non-malignant disorders. And I think that is not without importance because there is also a big indication there. One of the advantages, as also stressed already, of Triosulfan is that it, from a chemical point of view, it does not require activation or metabolization in the liver. Sort of, it avoids this first pass. That's why liver function is generally not an issue for this drug. It is for some other drugs that we use for conditioning of patients. It was stated that it is a, quote, reduced toxicity regimen, and I certainly agree with that. The important part, however, is that it is not a reduced intensity regimen, which is sometimes overlooked by my colleagues. In fact, it was initially, even prior to the development, as Mr. Edelman was just saying, for transplantation, it was used in Europe for treatment of solid tumors, in particular ovarian carcinoma. And there, the limiting side effect was marrow suppression. And that, of course, made it almost logical drug to be tested in the conditioning of patients for marrow or stem cell transplantation, if you wish. So it is a high intensity and quite efficacious drug with very little toxicity. In fact, we have carried out at our center most of the transplant in the clinic, in the outpatient setting, patients not requiring treatment to the hospital, which of course patients like, and certainly our health resources appreciate. In fact, it was so well tolerated that we could add, for some other indications, a low dose of total body radiation, which still did not induce any prohibitive toxicity. It is also important that the target in the European study and most studies done here were AML, acute myeloid leukemia, and myelodysplastic syndrome, which are indeed the two most frequent indications for transplantation currently. And as you also heard, the use is growing, approaching 10,000 patients per year in the United States. One comment on the toxicity, particularly in the pediatric population, where one major concern always has been for the decades that we have been doing transplants is impairment of growth and development. Triosulfan appears to have very little effect, and if our large animal preclinical models can be extrapolated, as we also have been doing for a long time, it may not even interfere with resuming reproductive activity after transplantation. Certainly has been tested in a large animal dog model at the NIH, as a matter of fact. So overall, the community is very enthusiastic. We had countless calls. When can we use it? When can we participate in those studies, etc. So I think we are waiting for this drug to be available widely.
Professor Deeg, are you able to review some of the data on the slides that Tina is presenting here?
You want me to add some specific comments?
Yes, please. We're hoping to walk through the.
All right, I can certainly try and do that. Well, as indicated here, listed on this slide are 3 by now completed trials, and again, most of, as you see, in AML and MDS patients. I have essentially said already what is relevant here as well, a tremendous tolerability at various dose levels, usually between 10 and 14 grams per dose, with excellent tolerance. And as I said, I emphasize that we have done, in fact, most of these transplants in the clinic outpatient settings. The next one, MC fludarabine T7 AML trial, was a phase 2 as indicated here, and yielded very promising, encouraging results in regards to anti-leukemic effect and long-term survival. And the same is true for the third study listed here, focusing on MDS with very similar outcome, maybe even slightly better than in patients with AML, which may have to do with the disease pathophysiology. Well, this is just more of the same, not to bore you with unnecessary details. As we said already, there have been phase 1, 2, and phase 3 trials. I referred to the doses, and they are shown in bold here, the range between 10 and 14 grams per meter square per day as part of the regimen, usually in combination with fludarabine, another profoundly immunosuppressive drug that is also used for non-transplant purposes in patients with malignant diseases. And again, as we have been saying, the results in all these studies were really positive. I try not to say encouraging, because I think if they hadn't been encouraging, we wouldn't be going where we are going now into a broader indication. As emphasized by others before, these Triosulfan, there is only one narrow indication for any other drug that has been used, approved for conditioning, that was Busulfan for chronic myeloid leukemia. But since we see very few patients with CML for transplantation currently, the availability of Triosulfan and indication for a different disease group is very relevant. Well, this summarizes data on studies which enrolled patients with different diseases, as listed here, but again, mostly AML, MDS, and then also some mature B cells. Combined total, as indicated here, of 563 patients, and with excellent safety outcome. I think we have another slide on that, if I'm not mistaken. No? No. Well, not sure how much I should comment on the text that is shown here. You can certainly read it. There was a temporary suspension after 330 patients had been enrolled. There were discussions about the optimum dose, but that decision really was dependent upon what the comparator would be. If we use Triosulfan at higher doses, eventually, of course, you will get toxicity. But if you want to compare it to a regimen with what is thought to have comparable efficacy, then it turned out a lower dose of Triosulfan was absolutely sufficient. And that is also what allowed us, and I have said that already, to do many transplants in the clinic outpatient setting. The rest of the text is sort of administrative stuff. The study was completed, and the remaining patients were treated at a reduced dose of Triosulfan. I don't think that requires any additional comments, and the data have been published. Initially, there will be follow-up papers by the European groups led by Dr. Behlen in Essen, as indicated here. The paper came out in Lancet Hematology last year. And as you can see here in the two columns headed Triosulfan and Busulfan side-by-side comparison, the patient populations were very comparable. Most of the patients received peripheral blood progenitor cells, and only few received bone marrow as a source of stem cells. So it's a more convenient way of obtaining the stem cells by collecting them from peripheral blood. The engraftment, as indicated here by complete chimerism, which we usually determine at 1 month, 28 days, and around day 100, was in fact slightly higher with Triosulfan. We do not have later time points, let's say 6 months or so, to compare again, but that was certainly a very important finding, and that there was no problem with engraftment, which some people had feared would be the case because we didn't really see much toxicity. The question came out, well, is that an indication that we have less efficacy? Obviously not for engraftment, and you see even a p-value given for both time points, day 28 and day 100. The overall survival is shown here, 71% versus 56%. As was said before, the study was originally designed as an non-inferiority study, and clearly the Triosulfan combination was not inferior. In fact, turned out to be superior, also reflected in an improved 2-year survival at 64%. The transplant-related mortality at 2 years was only 12%, which in some studies, in fact, it was only 10 or 9%, definitely lower than with Busulfan. Hence, as emphasized repeatedly before, the reference to this regimen as a reduced toxicity regimen with comparable efficacy. The relapse incidence was similar, 24, 23% at 2 years. Graft versus host disease, if anything, was extensive chronic graft versus host disease, if anything, was somewhat lower with Triosulfan, which may have to do with the fact that, not to go into great details here, if you have less toxicity of the conditioning regimen, apparently you do less tissue damage, almost by definition, and having less tissue damage is a situation where you are not as favorably setting the stage for developing GVHD as if you have a lot of tissue damage with all kinds of cytokines floating around. GVHD-free survival is shown here also, and both GVHD and relapse-free survival, as many people like to refer to now, Griffiths, was superior with the Triosulfan. Very few side effects of significance.
Yeah, Joachim Baumgart speaking. May I add a short comment to
Please, go ahead.
This presentation? If you go back, please. Yes, I only want to mention Joachim Baumgart from Medexus speaking, that we submitted trial results on the base on the non-inferiority estimation as mentioned by Joachim Deeg. This submission was done in Europe at the EMA, but for the US submission of our new drug application, we included the trial results of all 570 patients with a longer follow-up as submitted to the European authorities. And we have included superiority testing in this submission, which is under review by the FDA currently. So we are hoping that the FDA will follow our final result submission with a longer term follow-up compared to the European submission, and will hopefully confirm a superiority claim as submitted by our company. This is, I think, important to mention for the slightly different database which was submitted on request of FDA for our new drug application here in the US. Thank you for this.
This is Joachim Deeg again. One more comment. Most of these studies, I don't think we explicitly stated that we're done with HLA identical donors using peripheral blood or bone marrow, I would like to add that similarly encouraging results have been obtained with umbilical cord blood as a source of stem cells, and which has been and is still an important source of stem cells, particularly for patients from ethnic minorities, where it is sometimes difficult to find a HLA-matched donor. And very importantly, studies are ongoing now using a triosulfan-based conditioning for patients who are to receive an HLA haplo-identical transplant, for example, from a child or sometimes from a parent if the patient is very young, which is a development over the last 5, 8, 10 years by now, but really gaining tremendous momentum as another aspect of allogeneic transplantation, because almost anyone has an HLA haplo-identical donor. So further widening the ability of applying that strategy. You want me to, there's not much to comment on that. I mean, we have said all that before, but just show it graphically, shown in blue here from the trial as indicated is the survival among patients given the triosulfan-based regimen, 64% 2-year survival. And in purple broken line, the results with Busulfan showing a 50% 2-year, 24-month survival. And this is, can you go back to the previous slide? Sorry. Yeah, so should have. This is the event-free survival, so no relapse. And the next one, next slide is the overall survival. Similar difference, somewhat higher because a number of patients were rescued by additional therapy. And indicated here is the treatment-related, or what we often call non-relapse mortality, as we said earlier, was in the range of about 12% for the triosulfan, shown in blue here, and was some 25% or thereabouts, 28% actually, for patients conditioned with Busulfan, shown in purple. Well, just to read through that, there is good evidence that a triosulfan-based conditioning regimen is associated with a very favorable outcome after transplantation. And apparently, based on all the studies that have been done and which we have discussed, outcomes superior than what is otherwise probably the most widely used regimen, Busulfan and fludarabine, or Busulfan and Cytoxan, although that was not the direct comparison here. Just repeating what we have been saying, the outcome, overall survival was significantly higher in these AML and MDS patients. In all fairness, one will have to say that it will remain to be seen whether this superiority occurs also in patients with other indications. But as we emphasized before, AML and MDS are currently the most frequent indications of malignant diseases for allogeneic transplantation. And the last paragraph is, I think, of interest, if we can go back one more time, is that a matched pair analysis done by the European bone marrow transplant group shows, again, a superiority of triosulfan, which was also shown in an analysis conducted by the Center for International Bone Marrow Transplant Research with a seat in Milwaukee. Yeah, I don't think I have to comment the studies on the previous slide. We're done studies done on this continent, in fact, in the US, in both adult and pediatric patients, all coming out with a favorable assessment of Triosulfan, and here are various centers that participated in those studies. And I have said that already too. It also includes pediatric patients and, importantly, as emphasized before, non-malignant diseases. And this lack of toxicity and hopefully a lack of a negative effect on growth and development in these young patients is a very important aspect of what we're looking at. We'll continue to follow, of course, since we need longer follow-up with patients, with more patients going through puberty and see what their recovery is.
So thank you, Professor Deeg. Great insight into Triosulfan, and appreciate you coming on with us today to discuss some of the clinical data that you've done, and appreciate all the work that you've done behind this drug. So yeah, thanks so much for being on here. We'll open up to question and answers. If anyone has any questions, you can send me an email at tina@adcap.ca, or you can input them into the Q&A box. So I guess, Professor Deeg, if we can get you back on for a moment, maybe we can talk about the autologous market, which I know that the company is looking for approval for allo-HSCT, but there is this other market that could be potentially quite large as well. Can you provide some color on the potential in that market?
For autologous transplants, you mean?
Yes.
Yes. Well, autologous transplants are not really transplants since you infuse the cells to the same person from whom you have collected them. So that is not just a question of words. That's a term that people use. It's really here in the autologous setting, what we do when we do a transplant in quotation marks is we give high dose therapy and then rescue basically the patient by reinfusing cells previously collected. But this is, once again, where the very important aspect has to be emphasized, that the original observation was that the dose-limiting factor of Triosulfan without stem cell rescue, autologous cell infusion, was marrow suppression in these patients with ovarian cancer. So that can be taken now to different disease indications as long as we are able to harvest sufficient cells for an effective rescue following the high dose therapy. Whether that would be in the autologous setting only with Triosulfan or in combination with other modalities, I think that's an open question. What we do not need here is a component that will suppress the recipient's immune system. In other words, we don't have to be concerned about rejection, which theoretically at least and in practical terms could be an issue with allogeneic transplantation. But with the patient's own cells, that's not an issue. Hence, here the emphasis is on as effective an ablation of the disease and then salvage by the infusion of the previously collected stem cells. An important part, of course, as far as disease eradication is concerned, an important difference from the allogeneic transplant setting is the fact that we will not have a quote graft versus tumor effect, since the cells are identical to what the patient had, although there are studies going on modifying autologous cells, genetically engineering the cells so that we could add such an effect even in the autologous setting.
Is Busulfan currently being used for the autologous in the autologous setting?
I don't think anyone is using Busulfan in the autologous setting. No.
Okay.
No.
And to clarify, so Busulfan is not technically approved for the allo-HSCT indication.
Say again, sorry?
The Busulfan is currently being used off-label for allo-HSCT.
Well, for allo, as I said, it had been approved for a chronic myelogenous leukemia, chronic myeloid leukemia, many years ago. But that was the only label indication anyhow. Yeah.
And you mentioned some some other studies that you've been working on. What are you studying in your in the center's investigator-initiated studies for evaluating Triosulfan?
Well, I mentioned one already. That is a study using haploidentical donors. That is, of course, again, a situation where the engraftment question is relevant, since we are infusing cells from a donor who is only half matched with the patient. So that is an important aspect of that study. At the same time, we could have more of a graft versus leukemia effect because of that mismatch. And we are using the so-called post-transplant PSI, in other words, give Cytoxan after transplantation, as developed originally by the group at Hopkins, in an effort to more selectively eliminate cells that are the culprits in initiating graft versus host disease, which is still one of the stumbling stones. And we will see whether there is any, or we will determine any interaction, or whether that effect is different in patients who have a conditioning, a Triosulfan conditioning regimen, rather than some of the other regimens, fludarabine, radiation, that have been used. So that's a major study. And the other ongoing studies are in patients with non-malignant disorders, bone marrow failure states, immunodeficiency disorders, where very little or no other treatment options are available.
You also mentioned the potential to add low dose body radiation with some of the patients due to the high tolerability of Triosulfan. How much work has been done, or how?
Well, there is a lot of work that has been done with low dose total body radiation in a number of different regimens, often combined with fludarabine, in some studies combined with fludarabine and melphalan to intensify that regimen. And as I said earlier, we have also used it here in combination with Triosulfan and fludarabine. And it seemed to add, it was a phase 2, it was not a phase 3 randomized local study that we did in patients with AML, acute myeloid leukemia. The addition of 2-gray low dose and total body radiation appeared to add to the anti-leukemic efficacy. The survival was improved, although we did not quite reach the classical statistical significance. But clinically, the impression was that the addition of TBI, which did not add significant toxicity, improved outcome in AML patients.
Okay, that's great. And you seem enthusiastic about being able to use Triosulfan with patients. Can you talk about the medical community in the United States? How aware are they of Triosulfan and the work that you've done? And do you have a sense of what the reception will be like in the medical community?
I think our colleagues at many centers are quite familiar with the data and have been. As I said earlier, we have had many calls. When can we join, or when will the drug be available? What is a projected approval, etc. So I think there is a very keen interest, once again, because of the very low toxicity, which is indeed remarkable, and the maintained or still, despite reduced toxicity, showing the same or even superior efficacy in comparison to other more established regimen. So I think the reception is or will be very enthusiastic, and I think we will see many patients transplanted utilizing a Triosulfan-based conditioning regimens. They will probably be modified. There may be other add-ons, different cell manipulation. I mentioned already some before, genetic engineering, etc. But I think the reception will be quite enthusiastic.
We had a question from the audience. Given the improved tolerability, do you anticipate more vulnerable AML and MDS patients receiving allo-HSCT therapy, and what kind of patients would you expand this?
Yeah, no, very good question. I mean, the data that have been accrued so far have been in patients up to 70 years of age. There is a growing number of patients older than 70 years of age who are being transplanted. And that is certainly one target population where this low toxicity regimen will be of interest. In fact, we are about, I hope, to activate a study, another phase 2 randomized trial comparing a Triosulfan-based regimen to a clofarabine-based regimen, which was also tested in some other settings for higher risk patients with myeloid malignancies, going a little bit beyond what the previous studies have included, and for patients with significant comorbidities in an effort to determine how far we can go in accepting patients for transplantation utilizing these more novel regimens.
What kind of patient population size would you be looking at for a study like that? And would it be similar over the course of 2 years, or how long would that take to accumulate?
Yeah, this particular study to which I just referred is targeting 80 patients. And we hope we can accrue those patients over, it may probably be a little bit more than 2 years, 2.5 years, but that is not unrealistic.
And just as a reminder, we're talking often in comparison of Busulfan to Triosulfan in terms of intensity. So can you give us a comparison of the dosage, or the appropriate dosage for Triosulfan versus Busulfan?
Well, okay. Let me expand a little bit on that. I mean, Busulfan is used in doses people refer to as Bu2 or Bu4. In other words, Busulfan given for 2 days or Busulfan given for 4 days, the classic regimen in combination with Cytoxan or fludarabine, for a total cumulative dose of 16 milligrams. Generally, it depends upon, we give it IV or PO, either every 6 hours in divided doses or every 24 hours for only 4 doses. And if in the lower regimen, lower dose Bu2 generally only 8 milligrams, or even lower, 7.2 in that range. And Triosulfan, as I said, has been used, and we have shown that at doses in the range of 10 to 14 gram per meter square per day for 3 doses. So the doses are in a different order of magnitude. We give milligram doses of Busulfan, and we give gram doses of Triosulfan, and so that is not really comparable, and that to a large extent has to do with how the drugs are metabolized. I mentioned before the sparing of the liver, so to speak, with Triosulfan, whereas Busulfan is very much dependent upon hepatic metabolism and is an enzyme inducer also in the liver, in hepatocytes, which then leads to altered metabolism of other drugs that are given following Busulfan. And I think that may also be part of why we see less toxicity with Triosulfan, where that is not the case.
Okay, I think that's all the questions that we have for you. Really appreciate you coming on and giving us some color on all the work that you've done with Triosulfan, and appreciate the work that you've done. I know that it's a significant treatment regime that can really affect survival outcomes. So thank you so much for being here. I'll leave it to Ken for concluding remarks.
You're welcome. Thank you, Tina. And yes, I also want to thank Professor Deeg for sharing with us his vast experience in this area, and also to Dr. Baumgart from Medac for sharing with us his experience in preparing this drug for registration. And so, I'm sure as you've seen and heard the comments from our expert, that we're obviously very excited to get this product to market as soon as possible. We certainly know that there is a strong demand for it, and clinicians and patients are hoping for it. And we believe that we can do that shortly after the PDUFA date in August. So again, we're very excited to be bringing this to market to help save patients. And so thank you very much for spending some time with us today. And I want to thank our experts for joining us today. Thanks very much.